So, hello friends. So, I'll be giving an overview on the key hemodynamic articles related to cardiology and hemodynamics that may be pertinent to our ICU practices. So, what I've done is I have gone through the key articles that have come out in 2024 pertaining to hemodynamics bar cardiology. So this talk I was meant to give in Calcutta for the Dr. Subhash Todi's meet that happened in Manipal on 23rd Feb 2025. So this should be useful because I have gone through month-wise on looking into various sort of articles reviewed to see which one may be more pertinent to us. So some of the journals that I've been covering 8 sort of an articles in next maybe 20 to 25 minutes. So the journals that I covered is there were 2 interesting trials that came. So this is very interesting. So the MINT trial and there was another one looking at restrictive versus liberal transfusion in myocardial infarction. So I think there has been a little bit of a paradigm shift on the transfusion thresholds. I think in the previous video you saw that in neurology there were signal towards maybe perhaps benefit with higher sort of a hemoglobin thresholds like 9 appeared better as opposed to the restrictive. So I think similar trend seems to be evolving even in cardiology. So we'll just talk about these 2 trials. And the MINT trial actually came in November 2023 in NEJM. And the same authors did this meta-analysis which came in NEJM evidence. Then we look into Lactal randomized multicentric study, or the Lactal trial that came in chest. So this is to look into precise fluid resuscitation based on certain tools like bioimpedance they used in this. And then we look into this Korean article, which again looked into very precise sort of a fluid resuscitation, looking at the extracellular water bioelectrical impedance. So they looked whether precise sort of a fluid resuscitation had any bearing with regards to outcome as opposed to sort of a liberal sort of a approach with standard sort of a tools that we may have. So these are very interesting trials for our ICU trainees. So Lactal trial that came in chest and the bioimpedance based fluid resuscitation with regards to the outcome. So we look into these 2 trials. Then for all the ECMO enthusiasts, we had this danger shock study that came in NEJM. It created a bit of a buzz in the extracorporeal sort of a enthusiast. So this was mainly looking at the impeller device and whether it changes the outcome in the patients. And then we had this SuperAdd trial, again for people who look towards albumin as a tool. So this came in Annals of Surgery, whether albumin has any role with regards to any outcome benefit. So then we look into, for intensivists who are interested in ultrasound, echo, cable ultrasound, acute heart failure study. This came in American Heart Journal. So again, looking at the utility and the value of the cable assessment, which is in IVC assessment and fluid de-resuscitation targeting IVC as a means, whether it influences outcome in the heart failure study. Then the last one that we'll talk is Landi-SEP trial, which came in intensive care medicine, basically to look at role of landiolol, which is a ultra short-acting beta blocker in sepsis patients. Because we have looked into the evidence, there's a video of mine where I've spoken about the role of esmolol and beta blockers in sepsis. As a continuum of that, this landiolol trial came, so Landi-SEP trial, so which we'll talk about. So now we look at this author first. It's a Carlson et al. So this came in December 2024, which is a sort of a meta-analysis, restrictive versus liberal transfusion in myocardial infarction. So they looked at 2 groups, liberal and restricted group. So liberal had hemoglobin, if it was less than 10, they gave transfusion. And restrictive, like in any other trial, hemoglobin 7, if it was 7 to 8, they gave transfusion to maintain the targets. So the primary outcome in this particular study was to look at the composite, because all cardiology trials, they look at the composite of 30-day mortality and recurrent MI in these patients. So when you look at the results, so here they took 4 trials and most of the weightage of the trial came from the MINT, because the MINT trial, which I'll be talking, the key author is Carlson. So he had done the MINT trial, and in MINT trial, they showed some signal towards benefit with liberal, and they wanted to extrapolate that or strengthen it, and he went ahead and did meta-analysis. So they took 4 trials, 4,311 patients. So as you said, the primary outcome was composite of death and your so it's a composite of death and recurrent MI. So if you look at restrictive and liberal, so as you see, there is no statistically significant difference between the restrictive and the liberal group. But when they looked at death at 30 days, again there was actually no difference, because if you look at the confidence interval, it is not significant. So death at 30 days, there was no difference between restrictive and liberal. But what they found is cardiovascular death at 30 days, that was significantly less in liberal group. If you look at the confidence interval, it becomes significant. So, which means to say that the liberal group had less cardiovascular death at 30 days, that became significant. And the striking one they found was all-cause mortality at 6 months was significantly less in the liberal transfusion group. So again, there are signals in neurology and in cardiology towards having liberal transfusion, trying to maintain hemoglobin at around 9 to 10 or 10 is what this particular meta-analysis shows us. And heart failure, as you see, there was no significant difference between restrictive and liberal groups. So there were signals towards cardiovascular death at 30 days and all-cause mortality at 6 months was significantly less in the liberal group. So the conclusions they made was, when you look at restrictive transfusion HB, the composite endpoints, which was a 30-day and MI, there was no difference. But restricted transfusion increased all-cause mortality at 6 months. So that was the conclusions they made. So liberal was better because the liberal group had less all-cause mortality at 6 months. So this was the conclusions the Carlson group drew from the meta-analysis. And prior to this, there was a MINT trial that came again in NEJM. So it was a US and the Canadian group. So that came in November 2023, where they compared liberal and restricted groups. Same, hemoglobin less than 10 was liberal, hemoglobin 7 to 8 was restricted. Primary outcome in the MINT trial was same composite of 30-day mortality and MI. And when you look at the results here, so they had 3,504 patients. So they had 1,749 patients in the restrictive and 1,755 in the liberal group. And of course, in the liberal group, they had more blood. More blood was given. So when they looked at the primary outcome, so as you see, primary outcome, there was no difference between the liberal group and the restrictive group, and it was not statistically significant. And death between the liberal group and the restrictive group, there was no difference. As you see, confidence interval and statistically, this was not significant. And recurrent MI, also, there was no difference. So basically, this particular trial really did not show difference. So he went on to did a meta-analysis taking another 3 trials and tried to show that restrictive possibly had more harm. So the conclusions they made was, in this particular MINT trial, if you give liberal group, hemoglobin less than 10, if you give blood, there was no benefit in reducing 30-day mortality or recurrent MI. And here they showed in restrictive group, possibly there were signals towards potential harm cannot be excluded. Although, as you see, in restrictive, there were little more deaths, as you see 9.9, but they did not attain statistical significance. And if you see recurrent MI, it was more. That's what they made. Since there was a signal towards causing more harm, they tried to do meta-analysis and showed and proved that liberal may be better off because restrictive had more mortality at the end of 6 months. So these are 2 interesting trials done by the same sort of an author. So they, like in neurology trial, we looked into the trained randomized control trial and we looked at the Hemosyn trial. And the trained randomized control trial did show that liberal is better. So it's very similar to that in cardiology parlance. So now we look into this particular trial that came, Lactal randomized multicenter trial. This came in chest in November 2024. Here they looked at carbon dioxide and oxygen derived indices, algorithm based carbon dioxide, and they looked at venous carbon dioxide and arterial carbon dioxide difference as an index of cardiac output and tried to titrate the fluid based on that derivative. So they had an algorithm put in place to look at the difference between the venous and arterial CO2 derived indices, and they looked at this difference as a tool of cardiac output, and basing fluid resuscitation based on that. So they looked at the gradient. So this is central venous carbon dioxide minus PaCO2 divided by arteriovenous oxygen content ratio. So they looked at this as a tool to guide fluid resuscitation, and they looked at it as a representation of tissue hypoxemia, and they looked at it as a representation of global metabolic demands. So they looked at this index. It was an algorithm based where they did some calculations between the venous CO2, arterial CO2, and the arteriovenous oxygen content ratio, and they created algorithms to titrate and calibrate fluid resuscitation based on that. So basically, trying to attain precise fluid resuscitation based on the tissue oxygen demands. And primary outcome was to see by doing this whether they could attain better lactate clearance. Better lactate clearance was lactate clearance of more than 10% could they attain in less than 2 hours. And secondary outcome was to look at the SOFA and mortality. So this is the sort of a trial, and it was a multicentric randomized controlled trial involving 3 intensive care units. And the inclusion criteria was patients who were more than 18 years and who had circulatory failure with lactate of more than or equal to 3. These were the patients. So they took 6 patients with lactate more than 3 and tried to put these algorithms and calibrate and titrate the fluid resuscitation based on this algorithm and see if it makes a difference. So what were the results? They took 179 patients, 89 were in the algorithm group. Algorithm group is where they gave fluid guided by your arterial and CbO2 difference, and standard is standard resuscitation. And they looked at whether lactate clearance more than 10% was better, and there was no difference between the algorithm and standard. And when they looked at median lactate clearance, again there was no difference. So although it was minus 2.7% as opposed to standard 10, which means the lactate clearance appeared a little better, but did not attain statistical significance. They looked at SOFA scoring. There was no difference between algorithm-based and standard. And they looked at ICU length of stay and hospital length of stay between the algorithm group and the standard group. Even there, they did not find any statistical difference. They looked at 28-day mortality. There was no difference between the algorithmic group and the standard group. So which means, precision-based fluid resuscitation based on certain advanced algorithmic variables really did not make a difference in the clinical endpoints is what they showed. The conclusions is carbon dioxide oxygen derived indices to guide the treatment did not attain lactate clearance more than 10% and did not make any difference with clinical improvement because they looked at length of stay, they looked at 28-day mortality, did not make any difference. So a very interesting study. Although we talk about precision-based medicine using a lot of gadgets and tools, it did not make any difference. And what they found interestingly is the blue one is the algorithmic group. So they needed less fluids, as you see, and that attained statistical. And the algorithmic patients needed little more dobutamine. So this is what they showed. So, and very similar to that study was this particular study from the Korean group, where they used bioimpedance, bioelectrical impedance, to look at the extracellular water, and they looked at a ratio to see again precision fluid resuscitation and precision deresuscitation helped in improving the outcome. So this was a Korean study where they used BIA's bioelectrical impedance assay, and they looked at the extracellular water divided by the total body water as a ratio, and they tried to target the fluid resuscitation. Inclusion criteria, they predominantly took post-surgical patients here, and volume optimization was based on the ratio of extracellular water and the total body water, and volume optimization was done on that. And if extracellular water by total body water was more, they used deresuscitation. They used furosemide, they used diuretics to deresuscitate. Basically, it was again like the previous study, precision, calibrated fluid resuscitation as a tools to see if it makes a difference to the clinical endpoints. And they took ECV by total body water 0.39 to 0.406 as a normal. So they strictly maintain the patients in this ratio as a precise fluid resuscitation in these patients to see if it will make a difference to their outcome. Primary outcome was to look at hospital mortality. Secondary outcome was to look at the post-surgical comorbidities and 28-day mortality. What was the results? They had 167 patients. They looked at the hospital mortality between the bioimpedance assay, 77 patients and 90 were in the control group. As you see, hospital mortality was 0 here, which you think is very good. but it did not attain statistical significance. It was 4.4% in control group. And if you see 28-day mortality, 28-day mortality was significantly less here in the bioimpedance assay as opposed to the control group. It was 14.4%. So which means to say that bioimpedance assay, it appeared that intervention group where they targeted this had some bearing on mortality reduction. And they looked at the patients where ECV by total body water was high, which means they had more extracellular water. It was found to be, if you look at the confidence interval, they were significant. It was an independent predictor of post-surgical comorbidities, which means they had more post-surgical problems if your ratio was higher. And CLI is capillary leak index. In patients who had higher capillary leak index, they seem to have more post-surgical problems, is what they showed in this particular study. So basically, the conclusions they draw is targeted fluid resuscitation based on this ratio of extracellular and total body water. So did not reduce hospital mortality, because that was the primary outcome, was they looked at hospital mortality. But the secondary endpoints was 28-day mortality did show reduction. So if you see the primary, because all your conclusions is based on the primary outcome. Primary outcome is hospital mortality. Secondary was 28. So it did not have an influence on primary outcome, which is hospital mortality, but it had a bearing on reducing 28-day mortality. So the previous study you saw that advanced algorithm based did not make any difference, but here it shows some signal that reducing extracellular water divided by total body water ratio, reducing this extravasation has some bearing on reducing 28-day mortality. If you have more extracellular water, it shows that post-surgical course can be more turbulent and they can have more comorbidities, is what it was shown in this particular trial. So then very quickly we'll talk about this danger shock trial. This was done by Denmark people and the German group. That's why it's called Danish. Danger is not being dangerous. It is Danish and German shock trial. It's a microaxial flow pump versus standard care in infarct-related cardiogenic shock. They used the impeller device here. Impeller device is the one which is used in an MI to offload the left ventricle and enhance your cardiac output. So here they took patients with ST elevation MI with cardiogenic shock, where they compared microaxial flow pump plus standard therapy versus standard. Primary endpoint was to look at death from any cause at 180 days. And secondary, they looked at composite safety endpoints, where they looked at the bleeding, hemolysis, and limb ischemia as the secondary endpoints. And they looked at device failure and the worsening aortic regurgitation as the composite safety endpoints. When you look at the results, the median age group was 67 years, 79.2% of the patients were males. They had 355 patients, 179 in the impeller group, who had MI and who had an impeller put into the LV to offload it, and standard was 176. And if you look at primary endpoint, which is death from any cause at 180 days, it was significantly less in impeller group as compared to standard group. That was statistically significant. But the complications, composite safety endpoints, where they looked at bleeding, where they looked at limb ischemia, hemolysis, device failure, it was high in impeller group. It was 24% as compared to 6.2%. That was statistically significant. And patient who underwent impeller needed more dialysis, because 41.9% needed dialysis as opposed to 26.7%. That was statistically significant. So what it says is it saved more lives, but these patients ended up having more complications, more bleeding, more hemolysis, more limb ischemia, and more dialysis. This is what they showed. So the conclusion is, in patients with ST elevation MI, impeller looks something like this. It looks like a snake. So ST elevation MI with cardiogenic shock using microaxial flow pump with versus standard did reduce the death from any cause at 180 days, but it increased the serious adverse events or complications or composite adverse effects were more in patients who had impeller. So that is the conclusion of danger shock trial. So then we look into another passionate one for many of the surgeons is using albumin. Goal-directed perioperative albumin substitution was a standard to reduce post-operative complications. This was a SuperAdd trial that came in Annals of Surgery conducted by the German group. It's a single-center randomized control trial. Inclusion criteria, they looked at high-risk patients who underwent surgery and where Serum albumin was less than 3. They tried to give albumin infusion to maintain more than 3. Primary outcome was to look at post-surgical complications after 2 days. Until post-operative day 15, they followed up for post-surgical complications using this index called Clavian-Dindo classification. So that is just a grading of different surgical complications. They took 2,509 patients. 600 of them, 23.9 patients, had serum albumin less than 3 grams, and they divided them into intervention and standard group. In intervention, they gave a median of 60 grams albumin to maintain more than 3 grams. Standard is where they did not give albumin, but even in standard group, if serum albumin was less than 2 grams, they did give albumin. So it is a little confounded by that aspect. 54 patients had less than 2 and they did get albumin. So they had 600 patients, 299 in the albumin group and 301 in the standard group. We did not get albumin if it was less than 3. When they looked at post-surgical complications, as you see, so there was no difference between the albumin group and standard group. It was not significant. So a very simple trial where they said in high-risk surgical patients, maintaining serum albumin more than 3 grams by administering albumin really did not make a difference, and it cannot be recommended is what came out of this particular SuperAdd trial. So then for our ultrasound enthusiasts, there is this particular trial that came, cable ultrasound acute heart failure, where they looked at inferior vena cava and lung ultrasound guided therapy of heart failure, a randomized trial done by Argentina group, came in November 2024 in American Heart Journal. It's a single center randomized control trial where they did daily quantitative ultrasound for these patients with heart failure by 8-zone method. Primary endpoint was to see whether at discharge, whether they had more than 5 B lines and whether IVC diameter remained dilated at discharge. So they looked at this as a primary endpoint. Secondary endpoint, they looked at death at 90 days and patients needing readmissions for worsening heart failure or unplanned visit due to worsening heart failure was the secondary. Basically, optimizing again de-resuscitation or diuresis in these patients using your ultrasound. By looking at B lines, more than 5 they should not have, and looking at the IVC, IVC should not remain plethoric. That's what they looked at. So results, they had this many patients, 60, very simple study, 60 patients, 30 in the cable ultrasound assessment and 30 in the control group. Primary endpoint was to look at the B lines. So more than 5 B lines, as you see, the number of patients who had B lines was significantly less, where they gave ultrasound guided diuresis, as opposed to the control group where stethoscope or other tools was used. They had more B lines, which means your diuresis was more effective, where ultrasound sort of assessment was done. And secondary endpoints was again, as you know, it's a death at 90 days or admission due to worsening heart failure, unplanned visit was significantly less. As you see, it was 13.3% versus 36, which means the readmissions due to heart failure or unplanned visits was significantly less in this group, in these 30 patients who underwent this cable ultrasound. And NT-proBNP reduction was more in these patients, where ultrasound and B-line assessment was done to guide the diuresis as opposed to the control group. And safety was similar between 3 groups. The conclusions they made was IVC assessment and lung ultrasound guided diuresis of heart failure was found to be superior in acute heart failure, significantly reduced subclinical congestion, significantly reduce their need for unplanned admissions or unplanned visit to the hospital. And that is something that cardiologists or others can sort of use it in their heart failure management is what we can deduce. So then the last trial that I would be covering is the Landi-SEP trial. This was done by a European group. So I've done a separate video on beta blockers in sepsis. So this is another one, Landilol for heart rate control with septic shock, multicentric randomized control trial. So the hypothesis is Landiolol is an ultra short-acting beta blocker, controls heart rate without the increase in the need for vasopressors. So open label randomized control trial done in 20 sites in 7 countries. Inclusion criteria is patients that took with septic shock with tachycardia. Primary endpoint was to look at the heart rate response of the Landiolol was used to calibrate and titrate the heart rate between 80 to 94 beats per minute in first 24 hours. And secondary endpoint was to look at 28-day mortality and adverse effects. So that was the secondary endpoint. So Shastri. So the results of this is 196 patients. 98 were in the landiolol group and 98 were in the standard group. So the primary endpoint, as you see, the ability to reduce the heart rate and maintain between 80 to 90 was better in landiolol group, and that was statistically. So they could attain good heart rate control by using landiolol. That we know. But secondary endpoints, what which they looked at 28-day mortality and adverse events, there was no difference. So they did not see mortality benefit. So the conclusions they made was landiolol ultra-short acting controls heart rate without increase in vasopressors, but it did not have any effect on 28-day mortality or in the adverse effects. So basically, this trial debunks some of the Esmolol study where it showed reduction in mortality, and the study failed to show any mortality benefit at the end of 28-day mortality or adverse effects. So that's about the Landi-SEP trial. So conclusions. So with regards to transfusions, as we see, there is a more direction towards liberal transfusion signals, at least from the meta-analysis, that maybe in cardiac patients, 7 may not be good enough. Maybe 8 to 9 or maybe 9 is something we can think of based on the newer evidence that is evolving in neurology and cardiology. And that came from the MINT trial and this meta-analysis. And precise calibrated fluid resuscitation based on carbon dioxide and oxygen indices failed to show lactate clearance, and there was no improvement in clinical outcome. And danger shocks trial, we saw that Impella has a mortality benefit, of course, comes with complications. And in high risk surgical patients, giving albumin and maintaining more than 3 grams cannot be recommended. And we saw using bioimpedance, thoracic bioimpedance using extracellular and total body weight water reduces hospital mortality, did not reduce hospital mortality, but did it show signal to reduce 28-day mortality. And IVC and lung ultrasound guided therapy in heart failure found to be better in significantly reducing subclinical congestion. And Landi-SEP trial, although it controlled the heart rate without increase in vasopressors, but it did not have any effect on 28-day mortality or adverse events. So request all of you to submit valuable work to Journal of Acute Care. You can visit my website to rehear to this lecture. So thank you. Thank you, Manado. Tilok sir, join ಆಗ್ತೀನಿ. I was just in the counseling, but just join ಆಗ್ತೀನಿ sir. I'm joining now. Yeah, I'll join now, sir. Thank you. The meeting ಇದೆಲ್ಲ ಸೆಕ್ರೆಟರಿ ಜೊತೆ ಏನಂದ್ರು